Okay, we're going to get started. We're going to talk about coronary artery disease. So if you have your book, we're on page 730, and we need to talk about coronary artery disease because it is a major, or actually the leading cause of death in the United States. It leads to angina, and angina can potentially lead to the patient having a myocardial infarction or an MI. All right, I love this picture. It's a great picture that shows you the major coronary arteries in the heart, the major arteries that can actually become occluded because someone develops what we call atherosclerosis, which is essentially fat deposits in the coronary arteries, and these fat deposits, to keep it simple, can harden. And so you can see, for instance, over here, on the right side of the heart, we have what we call the RCA, or the right coronary artery. This tells you what area or what specific area of the heart muscle this artery supplies blood to. Then we have the left side. As you can see, we have the left coronary artery that comes down. Major branches would include the circumflex, and then what we call the left anterior descending artery. And this gives you a good idea of which major arteries supply what area of the heart muscle. And this is important, for instance, when someone is having an MI and we come to understand what particular artery is actually occluded, then we can have a better idea of what potential complications this patient might have. Okay, so we are studying coronary artery disease. Specifically, we are studying atherosclerosis, which we already said is a buildup of fat deposits. What we need to understand is that this happens typically because of genetics, because someone has increased fat or high cholesterol, someone has diabetes, it's not controlled, someone has hypertension, it's not controlled. The fat deposits actually invade or build up on what we call the intimal lining of the artery. Remember, you have 3 layers to the artery. The intimal is the most inner layer. If you guys look in your book on page 731, there's an excellent picture that shows you the intimal layer. And so it shows you that this is where we have damaged first. And then you can see what happens is we have lipids that deposit. Eventually, we have what we call a fibrous plaque, or an actual cap forms. And then that cap becomes what we call a complicated lesion and can actually rupture. And this would potentially cause an occlusion of that artery and lead to someone having a myocardial infarction. The other thing to know is that there are a couple of different types of buildups. There can be what we call an eccentric buildup or a concentric buildup. This is actually showing an eccentric, where it is just one-sided. See, that's one-sided. As compared to if we had a buildup all the way around the artery wall, then that would be considered concentric. Also, it's important to know that most plaque buildups actually start at bifurcations, just because there's more surface area for the fatty substance to stick to or become deposited on. Buildups occur typically slowly also, buildup of fat deposits. And so this is actually a good thing because this allows what we call collateral circulation. And collateral circulation is when the smaller vessels, so for instance, if you went back to the previous picture, the smaller vessels or the smaller arteries would actually become larger than they should in order to carry more oxygen load or more blood flow. So we are specifically studying atherosclerosis, which we've said is progressive. Plaque builds up, damages the layers of the artery. We talked mainly about the intimal layer and the fact that this is where plaque can build up. And then you have the fibrous plaque or cap formation, and then a possible rupture. Do understand, though, as the plaque builds up and can invade into the second layer, the medial layer of the artery, then what we have too is an issue with smooth muscle contraction, because that is where the actual smooth muscle of the artery is. And so then that can interrupt the artery's ability to constrict and dilate as needed. We're going to talk about how atherosclerosis is the first step into someone developing angina, and we're specifically going to talk about what we call stable angina. A lot of times people actually call stable angina chronic angina too. Just another picture of showing you what happens when we have a plaque buildup that's eccentric, has the cap ruptures, and then we have a clot formation. This can potentially lead to tissue death. And so this is obviously what we want to avoid. This is a picture actually from your book on page 732 that just shows you how your body is able to compensate over time and develop what we call collateral circulation. Often when we talk about chronic diseases such as coronary artery disease, we talk about non-modifiable versus modifiable risk factors. And so the non-modifiables are outlined here. They're pretty obvious, as we age, we have an increased incidence of CAD. Gender, women have the protective factor of hormones prior to menopause, but after menopause, women are just as likely as men to experience coronary artery disease. Actually, women are 10 times more likely after menopause to die from heart disease than from breast cancer. You look on page 732, there's a nice chart that talks about, ethnicity. Whites, for instance, middle-aged white men have the highest incidence of CAD. African Americans, though, have a quicker or earlier onset and are more likely to have a higher mortality rate from CAD. Family history obviously plays a significant role in coronary artery disease. There are studies that show that there is a 40 to 60% genetic link making you more likely to have onset of coronary artery disease. Okay, so risk factors that are actually modifiable are located on page 732 and 33 in your book. Elevated serum lipid levels, specifically, for instance, cholesterol, fasting cholesterol greater than 200 increases your risk of CAD, as well, as well as a triglyceride fasting greater than 150 increases your risk. So we need to make sure people understand this. We need to make sure people understand the difference in what we call good cholesterol, which is the HDL, versus the bad cholesterol, which is the LDL. The HDL, remember, just helps to carry fat away for the liver to get rid of, which is desirable, obviously, whereas the LDL actually carries more cholesterol too and deposits it on the arteries and increasing your risk of CAD. So we want to make sure our HDL to LDL ratio is desirable. Obviously, hypertension consistently, meaning that a blood pressure is greater than 140/90, obviously roughs up the intimal layer of the artery, but levels or readings even lower than that if someone, for instance, has a history of diabetes. And so we really need to keep tight control of individuals' blood pressures. Tobacco use. These individuals, your book say, are 2 to 6 times more likely to experience CAD. What we want to make sure that we tell people who smoke is that if they would just stop smoking, their risk for CAD actually drops to those of non-smokers within 12 months, and so that's some good information to give to your patients. As far as physical activity and obesity, they can go hand in hand, so we want to just make sure that we promote physical activity, brisk walking every day, at least 30 minutes, 5 or more times a week, and that we ask people to look at their BMI, which is their body mass index, and to help lose weight gradually to help decrease their incidence of CAD. Diabetes, diabetics are 2 to 4 more times greater to experience in CAD than someone who is not, so we want to make sure that their hemoglobin A1Cs are actually less than 7%. Metabolic syndrome is just a cluster of symptoms that have been defined or identified as a risk factor for CAD. So for instance, an increased waist measurement, hypertension, elevated lipid levels, elevated fasting blood sugars. These guys are more likely to experience CAD. High or elevated homeocysteine levels have shown to increase the risk of CAD, so we want to make sure that we keep our homeocysteine level lowered. We can do this by increasing vitamin B6, B12, folic acids in our diet, and this helps to keep the homeocysteine levels lower. Okay, so in class then we will finish up about CAD, how we diagnose it, what's the treatment, and what is our nursing care for the patients that have CAD. Then that leads us into the fact that people who have CAD often develop angina, and angina is chest pain. We are specifically talking about chronic angina, which a lot of people call stable angina. And actually, this starts on page 740. I know this says 743, but it starts on 740. And so we're going to talk about angina and someone who has chronic angina and what we can expect. Okay, so now we're going to talk about angina, and we're specifically going to talk about chronic, stable angina. What happens is there's an issue between supply and demand. And someone specifically who has chronic or stable angina has an increase in demand or a need for oxygenated blood, such as, let's say, they walk up a flight of stairs and they have this narrowed artery, and usually someone will develop angina when the artery becomes approximately 75% occluded. And so they have this increased need for oxygenated blood, an increase in the demand, and because you have a narrowed artery, it cannot supply that oxygenated blood and nutrients that the heart needs, and within 10 seconds, when this runs out or becomes unequal, someone develops chest pain. They develop chest pain because they switch from what we say is an aerobic to an anaerobic metabolism, right? And they begin to produce lactic acid. Lactic acid is just that, it's acid, and acid is irritating to the nerve endings. And the nerve endings then send a message to the brain that, hey, I hurt. And this becomes interpreted as chest pain or angina. Someone who has chronic angina means that they have chest pain that is intermittent, but it is predictable. So for instance, I'm going to walk up this flight of stairs. It's going to cause me to have chest pain. I'm going to sit down. The supply and demand are going to equal out, and my chest pain is going to go away. Or I'm going to walk a mile. That could cause me to develop chest pain. I will sit down, take a nitroglycerin, and the pain will go away. So that is essentially what chronic or stable angina is. You have a narrowing or a fixed stenosis of an artery, and that leads to episodes of angina. I believe we've been over the majority of the info in this slide. Chronic stable angina is intermittent. The main reason people have it is because of atherosclerosis, which you've already talked about. And we already talked about the fact that someone who has chronic stable angina usually has a 75% or more stenosed artery. So, angina is reversible. So when you equal out the oxygen supply and demand, the pain or chest pain should subside. For a lot of people, the chronic angina is caused by activity, and it is usually the same type of activity. Now, if you flip to page 742, what you guys will see, there are different types of angina. There's what we call silent ischemia. There's what we call variant angina, microvascular angina. We are not going to study these in MP2. We are just going to study or focus on chronic. So again, chronic angina is when we have insufficient blood flow to the heart because of a narrowed coronary artery. This leads to a change in metabolism, a buildup of lactic acid, an irritation to the nerve endings, and therefore your patient has chest pain. In class then, we will pick up on collaborative care of the patient who is suffering from chronic stable angina.